We have other endocrine glands, pituitary, hypothalamus, but we're really focusing on adrenal and thyroid as for our exemplars. I'm not going to read every slide. If I'm not adding much to it, you can read the slides because I really want to make sure you have time to do the case study. So we're going to do thyroid case study, take a 10, 15-minute break depending on how long it takes us, 10-minute break, and then we'll come back and do adrenal and do an adrenal case study. Okay? So let's start with our thyroid disease, which is fairly common. To understand the endocrine disorders, if you have a good understanding of what the hormone does, it kind of all connects. It makes sense what the symptoms are, what the complications are, if you understand what the hormone does. And basically with endocrine disorders, it's either excess hormone, too much hormone level, too high hormone level that causes problems, or deficient, not enough hormone level. Okay, so kind of, it's pretty easy when you're learning it and reviewing it to compare and contrast, right? Too much hormone, too little hormone. What are the signs and symptoms? What's the treatment? If they don't have treatment, what's the complication? All right, so you guys saw the reading assignment. It's in the content section. And when we talk about the adrenals, there really wasn't much in Pearson, so we included another link that's in the adrenal content section, and I'll direct you to that if you haven't already read it. So basically, the thyroid hormone regulates a lot. It has a lot to do with our growth and development. It's essential for normal growth and development, including intellectual. So we'll see with congenital hypothyroidism, if not detected early and treated, it could actually cause mental retardation and intellectual disabilities. But the thyroid hormone does a lot more. It also helps control our heart rate, our blood pressure, fluid and electrolytes, reproduction, and regulates metabolism. So they're very small amounts hormones, but they are very potent and they regulate a lot of systems in the body. The hormone level is regulated by the hypothalamus and pituitary, which we're going to take a look at that because it really helps us understand, what could be wrong in causing the abnormal hormone levels. So again, just be aware there's not only thyroid and adrenal disorders, we have pituitary gland, we have parathyroid gland, we have the pancreas, which you talked about. So other endocrine disorders, but the common ones are the thyroid gland and the adrenal glands. So that's what we're going to address today. So again, the hormones have to be regulated. It's kind of it's a balance. You'll see on my first slide, it's a balance scale. If I have a slide that has like a continuum, there's a normal range, and then there's too high or too low, which could be a range. Obviously, the more abnormal level out of whack it is, the more symptoms and complications it's going to cause. But the hormones are regulated by a feedback mechanism, which involves the hypothalamus and the pituitary gland, which are up in our brain, right? Those two glands are up there, but they do help regulate the level of thyroid hormone. So when we think about what could be causing the abnormality, we've got to keep that in mind. So basically, the hypothalamus secretes thyrotropin hormone, which causes the anterior pituitary to secrete TSH, thyroid stimulating hormone, which then travels to the target hormone, down to the thyroid gland, which is in the neck, in front of the larynx. And that causes it to synthesize and release thyroid hormone. There's two thyroid hormones, T3 and T4, but we're going to talk about them collectively as one and just say thyroid hormone, because one converts to the other into an active form. So we're not going to differentiate for our purposes T3 and T4. There's no point. We're just going to say thyroid hormone. But it is regulated by this feedback mechanism. So you have a picture of it. and you have the graph. What sort of triggers the hypothalamus and the pituitary to secrete those stimulating hormones is the level of hormone in the blood. So it's kind of basic, almost like the thermostat in your house. If you set your thermostat at 70 and the house is 70, the furnace doesn't need to go on, right? If the hormone level's normal, then the hypothalamus and the pituitary don't need to secrete their stimulating hormones. If the level goes below, then it's gonna stimulate that to secrete the hormones that we need to get more hormone level increased, okay? Just like your furnace at home. If your temperature in your house falls low, then it's a feedback mechanism, then the furnace is triggered to turn on. So just think about that, so because when we talk about causes, we'll see that if there's a problem with the pituitary gland or the hypothalamus, that could cause a hormone problem. And it's called like a secondary hormone problem because it's a problem not with the thyroid gland itself. So you guys can look at this slide and you'll see the anatomy of where the thyroid is. When assessing it, we use a couple different methods. We use observation, of course. We look to see, does the neck look normal? Does it look enlarged? Gentle palpation is used to palpate, again, for enlargement or nodules. And auscultation at times, especially when hyperthyroid is suspected, because they could potentially hear like a swishing of brewing for hyperactive thyroid. There's a nice, I'm not big on the quickie review things, but if you want a nice little simplified explanation, I found a TED Talk that's this link here, that will describe the thyroid and what it does. So thyroid diseases can occur across the lifespan. In infants, we have a congenital form. It can occur in children, adolescents, adults, older adults. Okay, so it's pretty prevalent, thyroid disease, and it can occur across the lifespan. Pregnancy can also precipitate thyroid disorders. And one of the things to be aware of with adults, a lot of the symptoms are very subtle, and with all the endocrine disorders, they come on slowly, right? They don't just, it's not like you fall, boom, you break your leg. There's your clinical manifestation, right? You got a broken leg, swollen, painful, bruised. No, with endocrine disorders, the symptoms develop slowly and insidiously, so many times they go unrecognized for long periods of time, or as with the case with hypothyroidism, they can be mistaken for normal aging, right? Weight gain, dry hair, brittle nails, dry skin, tired, fatigue, mental status like slowness or memory loss. So many of the symptoms are the symptoms of aging. So if someone isn't astute at assessing, they might not be alert that could be hypothyroidism. There is a condition that babies can be born with at birth. It's called congenital hypothyroidism. Basically due, for some reason, there's an incomplete development of the thyroid gland, okay? So whether it's just a genetic thing, or maybe the mom was taking anti-thyroid meds, but babies can be born with it, and it can have severe side effects. Lethargy, bradycardia, hypothermia, but the most important thing, it can affect their intellectual ability, so they do screening in the United States. So in our country, in our developed country, we don't really see the mental retardation secondary to hypothyroid because there's like mandatory screening. And it's a simple test. And the cure, again, the endocrine disease is kind of easy. What do you think the cure is for any endocrine disease where you don't have enough hormone? You take a supplemental hormone, right? There's a supplement medication that we can use for thyroid disorders and adrenal disorders. But once you're diagnosed with that, it's a lifelong medication, which is important for nursing and teaching. It's a medication you're gonna have to take forever, and you should never stop it, you shouldn't run out of your medication, so that's an important nursing intervention. We said it can also occur in children at any age, and teenagers. One of my children's friends had hyperthyroidism around the age of 12 or 13, and she was that typical picture, very thin girl, kind of hyper, maybe had the bulging eyes, that exophthalmos, we have a picture of that, weight loss, kind of hyper, tremors, hyper. So remember, thyroid gland regulates metabolism, it affects heart rate, blood pressure, and there's treatment for both. So goiter just means an enlarged thyroid gland, okay? It doesn't tell us the problem with the physiological function, it just means it's enlarged. So goiter doesn't mean hyperthyroid or hypo, it means you have an enlarged hypertrophy gland. You have to do labs to tell what the physiological effect is, because it could be either hyper or hypo. So you have to do labs to determine that. The diagnostic tests are certainly labs are number one. And one of the most sensitive tests that they use is the TSH, thyroid stimulating hormone. So that's the hormone secreted from the pituitary gland in response to the blood level of hormone, right? If the hormone level is low, there's going to be an increase of TSH. So that's actually the test they use when they're regulating the thyroid supplement, the Synthroid. They use the TSH more than, they do look at the T4, but they'll use the TSH because it's so sensitive, thyroid stimulating hormone. In addition, they do a test called the radioactive uptake, iodine uptake test. So they administer radioactive iodine to the patient who's being worked up for thyroid disease. And the thyroid hormone absolutely needs iodine to be made. You have to have iodine to have the thyroid hormone. So then the thyroid gland takes up this iodine because it takes it up normally, but this is now in a radioactive form. And then they do sort of a scan and they see what the picture shows. If there's an increased uptake or increased absorption of iodine, it indicates hyperthyroidism. If there's a decrease, low uptake, hypothyroidism. In addition, if there's any nodules or any suspect of nodules or cancer, they can do a needle biopsy. And of course, always imaging studies help looking for any tumors or abnormalities. So ultrasounds, MRIs, and CAT scans. This is just a little chart of what we're gonna see in our labs for hypo and hyperthyroidism. So TSH is the thyroid stimulating hormone. So if the hormone level is too low, because there's a primary problem with the thyroid gland, the TSH level will be elevated. Okay, because always go back and look at the feedback loop there. However, you can sometimes have hypothyroidism because the pituitary gland isn't functioning, right? So what does the pituitary gland secrete that we need for normal thyroid? TSH. So some people you can have a pituitary adenoma, right? You can have a stroke that affects the pituitary gland. You could have head trauma. Whatever the problem, there could be a problem with the pituitary gland, and maybe the thyroid's perfectly normal, but the pituitary isn't producing the TSH normally. So that's called a secondary, that's the secondary cause. Obviously, the thyroid hormone level will be decreased with hypo, it's in the name, and it will be increased with hyper. In addition, the most common causes for hypothyroidism and the most common for hyper is in autoimmune diseases. So in general, what do you guys know? What's autoimmune diseases? Have you learned about any autoimmune diseases so far?
Basically, your own defense system savvy.
Okay, so this student said it's your own defense system. I like that, defense system. Yeah, it's our own antibodies attacking the thyroid cells. So they can check for, antibodies to see if it's the autoimmune form. And then the radioactive uptake we talked about. So this is just a continuum showing in the middle. So euthyroid is normal range. And for the endocrine disorders, for mine, I'm not talking about what Professor Anderson taught about diabetes. You do not have to memorize numbers of any levels, no numbers, but know what elevated or increased means and deficient. Don't memorize the numbers. You can look them up in the lab. You know, when you look in your labs, you can get the lab norms. But euthyroid means normal levels, right? And then it's a continuum. You can be a little deficient, a little low, hypothyroid, or you can be at the extreme, which would be the complication, mixed edema coma. So again, it's not black or white, cut or dry, or it's not like a pregnancy, you're either pregnant or you're not. You can be a little deficient, you can be more deficient, you can be extremely deficient and have like a crisis state. The same with the hyper. You can be a little bit elevated, you can be more elevated and be symptomatic, or you can be at that extreme end, which would cause a thyroid toxicosis, also called thyroid storm, okay? So remember again, these hormones have multi-system effects. It's not just affecting one part, it affects almost every function in our body, metabolism, growth and development, heart rate, blood pressure. So first we're going to cover hyperthyroidism. Excess thyroid hormone, again, it's in the name, hyper. We talked about the labs. The causes, the most common is the autoimmune disease, and that's called Graves' disease. Or someone can have a toxic nodular goiter, or it can be from a pituitary tumor that's secreting too much TSH, too much thyroid stimulating hormone, or it can be from excess thyroid hormone replacement in someone who's being treated for hypo. Maybe their dose is too high. I can give you an example of that. I've been on Synthroid for almost 20 years. But then I went to a naturopath doctor and they're like, oh, you don't have enough thyroid hormone, so they gave me some natural form to take in addition. And I took it on my way here. I almost had to pull over at Waterbury Hospital ER because my heart was racing. I just like literally felt hyper. Like my heart was racing, short of breath, tremulous, extremely like nervous. So I was like, oh my God, I'm not taking that again, obviously, it's too much, and my endocrinologist wouldn't have been happy because, again, it's like a fine balance with hormones, right? It's a fine balance. So, and the extreme complication of hyperthyroidism is called thyroid storm or thyrotoxicosis, which we'll talk about symptoms and treatment. All right, so the clinical manifestations, classmates wrote on the board. It's in your reading. I've put additional articles. We're going to do a case study. So again, remember what the hormone does. So what are some other symptoms that people want to add to this list? Any other symptoms you want to add to the list? Raise your hand or say it. What? Tachycardia. Tachycardia. right? And hypo is the opposite. You feel hot, heat intolerance. Haste is flushing, sweating. Yes.
Yeah, sweaty.
Sweating.
Yeah.
Good. Sweaty, hot, flushed. Yes.
Insomnia?
Insomnia, yes, you can't sleep. That's what you're gonna say? Insomnia. So everything's hyped up, right? All right, and what do we expect the T3 and T4? We're gonna look at this together. Thyroid hormone. What do you expect those to be with hyper? Those increase, but the TSH what? Decrease. Right. All right. And the most common form is raised. That's the most common, but not the only. All right, then we'll do hypothyroidism in a minute. So this is a picture of the X ophthalmos, which is those big bulging eyes, and it actually has a physiological cause where like polynucleosaccharides go in where they get in the interstitial fluid builds up behind the eye orbits, causes orbital edema, and then those bulging out eyes, protruding eyes. Okay, so this is a picture of that in addition to goiter. Okay, this is someone with Graves' disease. So with it, when they have that exophthalmos, we want to protect their eyes, right? Because they can have scratching and corneal damage, so you really want to protect them. And they're uncomfortable, itchy, dry, sensitive, kind of achy. So you protect them with artificial tears for lubrication, sunglasses definitely, sunglasses to protect from the sun. They may be on steroids or diuretics, and in extreme cases, corrective surgery. But once the hyperthyroidism is corrected, the symptoms will go away, but not suddenly. It's not gonna be in a week, it's gonna take weeks to get better. Nothing happens quickly. Remember, the symptoms develop slowly over time, and once treated, they're gonna go away slowly over time. So achy, tired, dry eyes, and the goal is to protect those eyes with treatment. So the treatment for hyperthyroidism depends on the cause, right? So if it's a tumor, they'll do surgery, right? If it's a pituitary tumor, they might do surgery, radiation. Until they get to do that, they may give them anti-thyroid medications to decrease the thyroid hormone level to relieve some of the symptoms. So there's medications, methimazole, PTU, radioactive iodine, that will help decrease the synthesis of thyroid hormones. This, the endocrine hormones are in chapter 44 of your Adams Pharmacology. So methimazole or tafazole is the first drug of choice. It has a few less side effects than PTU. It blocks the synthesis of thyroid hormones by inhibiting iodine. But again, it eventually, over time, if you're using these anti-thyroid meds, eventually, they will really stop the production and the patient may eventually be hypothyroid. All right, so these are not necessarily lifelong. And sometimes they take them until the other treatment can take effect, like with surgery or if, radiation. So we're gonna talk about the radioactive iodine. Radioactive iodine is another treatment, but it destroys the thyroid tissue slowly. Again, it's not a one and done quick fix. Usually they only need one dose, maybe 2 doses, but it occurs gradually over time. It destroys the thyroid tissue. So you're not gonna see immediate effects. It's gonna gradually reduce the thyroid function over months. There is side effects and of course the caution because of the radioactive iodine, especially if you are near children or pregnant women. So it is contraindicated obviously in children, pregnancy, and lactation. It can cause dry mouth, throat irritation. The patient, if they're of childbearing age, would need a negative pregnancy test before receiving radioactive iodine. And it's shed in the saliva, urine, and stool. So use your own bathroom, don't share utensils, don't prepare food, and avoid children like for 48 to 72 hours after getting like close contact. So nursing care with hypothyroidism, again, monitoring vital signs and cardiac rhythm because it affects the heart rate and rhythm. It can cause dysrhythmias. Offer, because their metabolism's increased, they're gonna be losing weight and thin, offer high calorie, high protein foods, frequent snacks, frequent meals, avoid stimulants like caffeine. Encourage periods of rest, alternating with activity. Try to help maintain a normal body temperature. They're gonna feel hot, heated up. Prevent complications. The thyroid storm is a complication. Educate about medications, signs and symptoms. Promote visual health, eye lubrication, artificial tears, sunglasses if they have the excess illness. The goal again is to reach that normal thyroid level and to relieve the symptoms. So I think I'm gonna ask, because I heard, did students here who were at St. Mary's have a patient that had hyperthyroidism? One of the professors told me that no one did. Maybe the patient was on. Okay. So there was a patient. Does anyone want to say? Okay, do you want to just tell us a little?
So my patient was 36 years old. He came in with palpitations. His heart rate was at rest in the 130s.
130s.
And the odd thing was we went around for a walk, and that would actually bring his heart rate down. And then going back into his room at rest, it would immediately go back up.
What did he look like? So she said his heart rate was 130. He was 36 years old and came in with palpitations.
He had just found out that he had Graves' disease 6 weeks ago. So he didn't have bulging eyes or enlarged goiter or.
Was he thin?
Yes, very thin.
Very thin. Was he kind of hyper? Or not?
He was anxious. Yes, he's which also, well, he had PTSD both as well. So that played a role too. But he was very anxious. And what I, like that, he educated himself about his disease, so he knew everything to look out for. He, with the palpitations, had the thyroid storm, so that's what they were treating with.
So you said he had Graves' disease diagnosed 6 weeks before. So now he went into a thyroid storm where his heart was racing, palpitations where he needed treatment. Did something precipitate the thyroid storm, like an illness or traumatic event or something, that you know of?
Not sure.
Sure. What was the treatment?
They put him on Tapazole and they were doing IV fluids.
They put him on Tapazole, IV fluids, anything for the heart rate, any beta blockers?
Propanolol.
Propanolol, excellent, you just made the rest of the lecture. The treatment. So when someone's got the Graves' disease and they get the thyroid storm and tachycardic, they can give beta blockers to decrease the heart rate. Tapazole was the anti-thyroid med, and IV fluids. Okay, so again, 36-year-old, so it's across the lifespan. And usually something, if they're already diagnosed with Graves' disease, or we'll see when we talk about hypothyroidism, Hashimoto's, usually something precipitates that crisis, or the worst case scenario. Trauma, increased stress, an illness, a virus, something like that. So the complication of Graves is just what we heard, that thyroid storm or thyrotoxic crisis, which could be life-threatening because their heart rate gets tachycardic. Rapid AFib is a common presentation. People who come in with rapid AFib, they'll draw their thyroid hormone to rule that out as a cause. And it's just hypermetabolism that can affect many organs, so it needs to be treated. Obviously, to diagnose it, they just need to draw the thyroid hormone level and the TSH. Tachycardic, high fever, cause heart failure, nausea, vomiting, diarrhea, abdominal pain, sweaty, we didn't have on this list, like tremulous, anxious. The treatment is to support their respiratory and hemodynamic status, identify the cause and treat it, and until that can happen, or maybe it's the autoimmune, you're gonna give the anti-thyroid medications, the methimazole or the PTU. If someone has a thyroid tumor or cancer, which isn't all that uncommon, thyroid cancer is one of the more common ones on the list. However, most of the time it's not malignant, so we're lucky there. So it's mostly not malignant, but thyroid nodules and thyroid cancer are fairly common, and the treatment could be a total thyroidectomy, removing the whole gland, or a subtotal, just removing one part of the gland. The benefit to that is you still have some production of thyroid hormone. So it can be a total thyroid or subtotal. And again, indicated for tumors, nodules, a large goiter, someone who has overactive thyroid that can't receive the radioactive iodine. And the big caution, again, think of where the thyroid gland is. So what do you think some of the cautions are when they have to remove it? Airway, or ABCs, right? So anytime you have surgery, there's some swelling, right? Edema during healing. So there could be bleeding, hematoma, edema, that could cause airway obstruction. So that's key post-op. In addition, the laryngeal, the voice box is right there. So laryngeal nerve damage is common. Okay. Also, there's 4 parathyroid glands, little tiny glands, basically inside the posterior part of the thyroid gland. So if the thyroid gland is taken out, they have to be very careful to leave 1 or 2 parathyroids. If they don't, the parathyroid glands could be damaged, and they regulate calcium and phosphorus. So we always check a calcium level whenever anyone has a thyroidectomy too, because they could have a hypocalcemia, which is exhibited with twitching, tetany. So they can have damage to their voice, vocal cords. I've seen patients who had thyroid surgery who then end up like permanently having a little like a white or raspy voice because they had damage to the vocal cords. Abnormal calcium and phosphorus because of damage to the parathyroids. And in the immediate post-op, the hematoma and edema could cause airway obstruction. If the thyroid gland is removed, they're going to require lifelong hormone therapy replacement. Post-op, we talked about, most important thing, monitor the airway, monitor for hypocalcemia, assess the voice. So that's hyperthyroidism in a nutshell. So now we're gonna quickly recover hypo and then get to our case study. So hypothyroidism is just what the name says, hypo, not enough, insufficient amount. And if you look at the little picture compared to the hyper guy was running, right? The hypo is falling asleep, I'm tired. I wanna put my head down on this desk and take a nap. No energy, tired, fatigued, right? Many causes, but the most common is the autoimmune. Again, our own antibodies destroying our thyroid cells, and that's called Hashimoto's. We always gotta have cool names, right? We got Graves' disease, and we got Hashimoto's. And you know why, because Dr. Hashimoto was the first one to discover it, right? More common in females, pretty common disorder. Hypo, what do you think the labs are gonna be with hypo? What's the TSH gonna do? Up. Just think, remember the feedback, keep looking at that picture. If your circulating thyroid hormone is low, what's it gonna signal your pituitary to do? Produce more thyroid stimulating hormone, right? So if your thyroid gland isn't making enough hormone to circulate around and regulate all the systems it does, it's gonna stimulate your pituitary, secrete more TSH, right? That's primary problem with the primary gland. Now, don't get hung up on this, because I don't want to spend an hour trying to discern this, but you could also have a pituitary problem, right? Say you had a stroke or a car accident and you had a bleed and infection in the pituitary gland, and it didn't secrete enough TSH. That's called secondary cause of hypothyroidism. So we're gonna focus on the primary, okay? So your TSH would be up, and what's your thyroid hormone gonna be? Low, because hypo is low, hyper, it's all in the name. Okay. Hypothyroidism increases a person's risk to develop cardiovascular disease, osteoporosis, angina, hypercholesterolemia, so we want to treat it. And the extreme is that myxedema coma. But myxedema, does anyone know what the word myxedema is? That's another cool word for our wordsmith people. Anyone look up myxedema in their taters or Google it? Wait, one person say it.
Fluid and fatty acid?
Fluid and fatty acid, yes.
Non-bleeding edema?
Non-bleeding edema. Yes, it's the mucopolysaccharides accumulating in connective tissue and interstitial, so puppies, right? Anyone have anything else to add to it? So the accumulation of these mucopolysaccharides in subcutaneous and interstitial fluid, which causes puppy face, puppy eyes, periorbital edema, puppiness. So our clinical manifestations are over there, students wrote on the board. If you have anything to add, let me know and I'll add it. No, it is hyper. I didn't look at the list too closely. Exophthalmos is hyper. Okay, so think slow metabolism. Slow metabolism means weight gain, right? Slow metabolism means constipation. Fatigue, decreased appetite, dry skin, depression, no energy, decreased libido, I don't want to do anything, hair falling out, dry thin hair, brittle nails. As you notice with the endocrine diseases, like unlike other diseases, there's a lot of visual changes, right, with the body. So if you can have people have like stage 4 renal cancer or liver cancer, you know, and you can't visibly see changes in their body. But with the endocrine disorders, thyroid as well as adrenal, we're gonna see a lot of changes in their appearance, right? You don't see that with other diseases, but with endocrine, you do. So thin hair. Menstrual irregularities go with both, okay? We said the thyroid regulates a lot of systems. So you'll see menstrual, a lot of times that's how women in their 30s are diagnosed. They can't get pregnant, infertility, they'll check their thyroid because it affects their menstrual cycle. Muscle aches, joint aches. And the treatment's easy. We have synthetic thyroid hormone that's pretty much the exact same chemical makeup as the thyroid produced in your body. It's called levothyroxine, T4. That is the most common thyroid replacement, levothyroxine or Synthroid. And in Blackboard, I posted a drug data sheet and asked you to fill it out for Synthroid. So in a week, I'll open up the one filled out, but for your learning, it really helps you learn better if you do the activity. So do the drug data sheet, and I'll open up the one I filled out. But Synthroid, a very common drug. I bet some of you even gave it to patients. Many patients are on Synthroid. It comes orally, it comes IV for sort of emergency situations. It's dosed and titrated, the dose based on the hormone level and the TSH level. So nursing education, always it's gonna be lifelong. They can't stop this medication. They should never run out. It's gotta be continually, every day. Should be taken the same time every day on an empty stomach. You can't eat an hour after. Many foods and other medications interact and decrease the absorption, so like it shouldn't be taken with vitamins or calcium or iron or antacids. It really needs to be taken by itself with a glass of water, first thing in the morning, so a lot of education around that. And they start at like a lower dose, then the doctor in 4 weeks will check the TSH level and increase it as needed to reach that normal thyroid level. So it doesn't take effect after 1 or 2 doses. It takes a couple weeks to build up. Nothing happens quickly, not in 1 or 2 days with these endocrine disorders. So you guys can read the info on Synthroid. Nursing care for hypothyroidism, monitor vitals, cardiac assessment, good skin care because they have dry skin. They do need exercise and activity even though they're going to be tired and achy and not feel like it. Increase fluids and fiber because constipation is a common clinical manifestation. Stool softeners may be needed. Encourage activity. Patient education about the medication, they cannot stop it, it's lifelong, don't run out of the prescription, take it on an empty stomach at the same time every day. Avoid sedatives. So think of our hypothyroid picture. The person's tired, they're sleepy, their metabolism low. So they're very sensitive to sedatives. So they may require a lower dose. So if they're given sedatives in the hospital, they may have an extreme like reaction, be more difficult to arouse because they're slow with everything. And then they're gonna feel cold. So the hyper was hot and sweaty and flush, right? Oh, I'm hot. This person's always gonna feel cold. They're gonna always want a sweater, their hands are gonna be cold, turn up the heat, they are very feeling cold. Right? When they go outside in the winter, they gotta make sure they got gloves and hats and scarves to keep their body temperature normal. As with hyperthyroid, we have the extreme thyroid storm. The extreme mixed edema coma. It's severe hypothyroid state. It can be life-threatening because it causes hypotension, hypothermia, hypoventilation. Everything's hypo. You get the picture, low, 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 right? Hypoglycemia, hyponatremia, to the point where they can be very lethargic, difficult to arouse, or in an actual coma. At that point, the patient would need immediate thyroid replacement, which you can give levothyroxine IV. And then all the vital functions would need to be supported, right? They may need a warming blanket to keep them warm, supplemental oxygen, IV fluids with dextrose in it and sodium. So just, that's what, when we talk about supporting treatments, whatever's abnormal they need, oxygen, IV fluids, warm up their body, anything they need to keep them stable. There's usually something, again, that precipitates this extreme case, an infection, trauma, exposure to cold, medications, or drugs. So certain drugs will mess up the level of hormone replacement, and those are amiodarone, that's that drug that has a lot of side effects, lithium. So certain drugs, you just have to, again, be aware that they may alter someone's thyroid hormone level. Amiodarone and lithium are just two, but there's a lot of drug interactions. That's why we say take the Synthroid without any, by itself, no other drugs, right? On an empty stomach, first thing in the morning, keep it out, don't take anything else for an hour, because many things interrupt the absorption of it. Medications, calcium, all these drugs can change the absorption of it. So here's a list of patient problems / nursing diagnosis. You guys can read that yourself. Health promotion is important with all our diseases, but again, there's a lot of teaching and prevent complications here. Avoid precipitating factors. So now I want us to, hopefully you guys have this on your, I don't know, if you didn't print it out, some of you have your laptop, we're going to do a case study. And you can work with friends in a group.
Did
So
you
we'll
print
take,
it out? You got it?
let's see, 15 minutes and see how far, and then we'll go over the answers together. So you guys, underline or highlight the abnormal findings, and then look at the labs and we'll see what the significance is. And then we're going to talk about the treatments.
Is this a 15-minute break or 15 minutes after the thing?
It's a 15-minute do the case study. When the break is going to be between thyroid and adrenal. I thought it'd be a good way to separate it, right? Well, we're going to finish thyroid, take a break, and then do adrenal. So go ahead and work in groups, friends, however you want to work on the case study for 15
Martha, I never
minutes,
sent you
and
the-
then we'll review the answers. Okay?
Yeah, DK.
perfect.
Regulation.
And actually, that's a good one, Nicole, that can go with pretty much all the endocrine. There's appearance changes with thyroid diseases, right, as well as the adrenals, we'll see. What else?
Regulation of body temperature.
Regulation of body temp, perfect.
Nutrition, less.
Nutrition, good, less than body weight. Good. Maybe anxiety, so we've got patient problems for our plan of care. What are some nursing interventions?
Vital signs.
Vital signs. That's our first thing to do. Fluids, monitor intake, right?
Tell them to avoid caffeine.
Avoid caffeine, good. And those other energy, Monster and all those kind of drinks, don't take any of that. That'll put you in a rapid heart rate, right? Good. Avoid stimulants, avoid what else? Avoid sedatives. Oh, that's sedatives, I'm getting confused too. How about with the weight, what else can you say? Yes, increase calories, have like high calorie snacks, nuts, peanut butter, not like, not candy, but good high calorie snacks, because you're gonna be losing weight. Yes, good eye care, sunglasses, protect your eyes. Protect your eyes.
Encourage the patient to verbalize their feelings.
Yes, thank you. Encourage the patient to verbalize their feelings. All right, perfect. So what is the general goal of treatment? To reach the what state? The euthyroid state, right? To reach the normal thyroid hormone level and help decrease or eliminate the clinical signs and symptoms. What's the potential complication that the nurse needs to monitor for? Thyroid storm, good. What signs and symptoms would alert you that this complication is occurring? Tachycardia, fever, palpitations, right? Hypertension, rapid AFib, good. And the treatment, the doctor orders radioactive iodine therapy and methimazole. Explain what radioactive therapy will do. Destroys the thyroid tissue slowly, right, over time. Is it for everybody? No, yes.
If it's slowly suppressed over time, is there a chance of reoccurrence of this happening?
No, usually they'll do if it's depending on the level, again, remember it all goes by, is it a little high, is it way high? They may give the anti-thyroid med while the radioactive iodine takes place over weeks. But once it's destroyed, it doesn't grow back. Good question. And eventually, so they may be hypothyroid and getting treatment for a couple of years, then eventually, once it's all destroyed, they will be hypothyroid and need levothyroxine or thyroid replacement.
Do they ever partially destroy it in order to keep some of the levels, or is it all or nothing?
I don't know that they can partially destroy it, but maybe a low dose. But if it's a cause that they could surgically remove, remember they could remove one lobe of the thyroid, leaving one lobe, which would have the benefit of having some, normal production and the parathyroid glands from being damaged. Yes.
Do they just inject it right into the
No.
gland?
No. I think they put it. It's oral.
Yeah.
They drink it. It's oral. And it's usually outpatient. So again, it's not gonna be a quick fix, it's gonna happen slowly over time. Because think of radiation treatments for any tumor, right? Most of the time, you're going for multiple radiation treatments over weeks or months for colon cancer, lung cancer, breast cancer, thyroid cancer. So this is radiation destroying thyroid cells slowly over time. What should we educate the patient about as far as precautions for the radioactive iodine?
Use your own bathroom.
use your own bathroom, use your own utensils. It's shed in the saliva, urine, and stool, so be careful around children and pregnant women, right?
Don't get pregnant.
And don't get pregnant, right? If you're getting the treatment, and if you're childbearing, they'll have a pregnancy test before we even start the treatment.
Could they get pregnant 6 months after they use, or they can't get pregnant?
I would think later after they could, but that would be a good endocrinology. I don't think it's forever you can't get pregnant. I would think after, maybe a year after the treatment, and it's out of your system. you could. So who wants to describe, what is methimazole? How does that work? Good, it blocks the synthesis, so it blocks even the thyroid hormone from being made, right? And that could be a temporary treatment until the thyroid hormone level is down, or until the radioactive iodine takes place, or until the patient has surgery, depending what's causing the hyperthyroidism. So what are some adverse effects of the methimazole? Again, it's chapter 44 in your ADAMS. So ADAMS it's kind of an easier farm book. They don't give you a lot of details, so I really encourage you when we assign the reading to look at it. It's never more than a page or two. It's really, they don't go into depth in pharmacology. But what are some of the side effects of methimazole? Hypothyroidism. Agranulocytosis, which means low white blood cell count, which would make the patient at increased risk for what? Infection, decreases your immune system. Is there any other treatment options for hyperthyroidism? Surgery, PTU.
Potassium iodide?
Yes, potassium iodide.
Yeah.
And there's glucose solution, which is the non-radioactive potassium iodide. Okay, so now take a 10-minute break and we'll come back and do the adrenal glands.
You have to buy it.
Christian, you want a snack? Snack. You can pick what you want
I'm gonna bring mine tomorrow just because I want to make sure I have something for the trick or treating. In case they do. Yeah.
It really didn't have much in your book about the adrenal disorders, or I felt it wasn't really covered well. We have this other reading assignment. It's a different textbook, Lamone and Burke. So if you click on it, it'll take a minute. It'll open up the textbook. So this is the assigned reading for adrenal. And then once it opens, it takes a while.
I know.
You go to the content, table of contents, and it's chapter 15. So let's see if it's gonna open. All right, so again, adrenal wasn't covered all that well in Pearson, so this is an additional reading assignment in course content. You have the link. If you go here to this table of contents under the house and click on it, you scroll down to chapter 19, nursing care of patients with endocrine disorders, okay? So in addition to Pearson, I assigned this for the adrenal disorders. Just wanted to make sure you guys could find that. All right, let's do our adrenal disorders. So again, we're talking about regulation and metabolism, as well as food and electrolytes. And the adrenal hormones are regulated with a feedback mechanism, the HPA, hypothalamus, pituitary gland, which are located in the brain, help regulate with their releasing and stimulating hormones the adrenal glands to produce and secrete the adrenal hormones. The adrenal hormones are essential for life. We cannot live without them, right? cortisol is the most important one. It's essential for managing and dealing with stress. So again, the primary disorder, when we talk about primary disorder, we're talking about a problem with the gland itself, the adrenal glands. Where are the adrenal glands located? On top of the kidney. So luckily we have two. Isn't it a bonus when we have two organs, right? We only have one heart, right? One liver. How many pancreas?
One.
How many lungs? Two. So you can have a lobe of your lung and still live. We have two kidneys, we can live with one. We have two adrenal glands, we can live with one. So, and the target gland is the adrenal gland. If there's a problem, dysfunction, the disorders with the gland itself, that's what's called a primary adrenal disorder. If it's because of a pituitary dysfunction or a hypothalamus, then it's secondary. So if you want to know what the primary and secondary. So the adrenal gland has two parts to it, the adrenal cortex, which secretes our glucocorticoids, and the most important is cortisol, again, essential for the body to live. And the mineral corticoids, which the most prevalent is aldosterone, it regulates sodium and water. And the androgens are the sex hormones for sex development. The disorders then we're going to focus on are Cushing's syndrome, excess adrenal hormone, and Addison's disease is the autoimmune form of an insufficient amount of adrenal hormone. There's two parts, however, to the adrenal gland. So the inner or medulla secretes two hormones, two catecholamines. They're epinephrine and norepinephrine, and you can have a disorder with that too, called the pheochromocytoma. But the exemplar that they chose is Cushing's and Addison's, so that's what we're going to focus on. So Cushing's syndrome and Cushing disease is from too much cortisol, excess adrenal hormones. Again, can have several different causes. If it's a primary problem with the adrenal gland producing the hormone, it's primary adrenal excess, or it could be caused from a problem with the pituitary gland secreting too much ACTH. So to back up, ACTH, where's our little, ACTH is the adrenal cortico releasing hormone, right? That stimulates the adrenal gland. Just like TSH came from the pituitary and stimulated the thyroid, ACTH is necessary for proper hormone levels of the adrenal glands, okay? So we're not just talking about one thing here that could potentially go wrong. We're talking about adrenal gland, we're talking about pituitary gland, and the hypothalamus. So ACTH is necessary to regulate adrenal hormones. Cushing's syndrome and Cushing disease is excess adrenal hormones, can be caused from adrenal tumors, pituitary tumors, or from too much exogenous, taken from the outside the body, steroid ingestion. So as you know by now, steroids are widely used medication to treat many diseases, right? Some people are on steroids lifelong to treat chronic illnesses like rheumatoid arthritis, right? Or some people take it for asthma or COPD. So steroids are given to treat multiple illnesses, and they may be given for long periods of time or lifelong. In that situation, they can cause a Cushing's syndrome. So again, with these endocrine disorders, we have changes in the physical appearance that we don't see with other diseases and illnesses. So for our clinical manifestations for Cushing disease, some students wrote some up here, right? And then here's the picture of the female. So we have the round face, or called moon face, fat pads, so fat, lipolysis, fat stores in abnormal places, like a hump on the back, the shoulders. So moon face, and then facial hair, or hirsutism it's called, that's the term for facial hair. Also, they have thinning skin that bruises easily. This woman has like a flushed face that we may see with it. So these changes we can see with Cushing's disease when there's an actual problem with the adrenal gland, or with Cushing's syndrome with someone who's taking long-term high-dose steroid therapy for some chronic illness. Another picture, this is from Pearson. Again, it's to the extreme, but I think if you look at the picture, it'll stick in your head. You know, the buffalo hump, the round face is from that lipolysis, the fat stores, emotional liability disturbances, so depression, anxiety, crying, it can even be psychosis, truncal obesity, thinning limbs, purple striae or stretch marks, hirsutism, irregular menstrual periods, bruising, high blood sugar. So think sugar. When you think Cushing's or hypercortisolism, sugar, right? High blood pressure, poor wound healing. You learned that with diabetes, right? If someone's sugar's high, they have poor wound healing. Depression, sleep disorders, fatigue. It can cause osteoporosis over time. So sort of the complications would be osteoporosis, hypertension, hypokalemia, type 2 diabetes it can cause. So Cushing's disease has lots of complications. Cushing's syndrome related to long-term steroid use. So you guys, did you learn about steroids in one last year? You did it as a drug. So there was a lot of side effects of steroids, right? Hyperglycemia, so type 2 diabetes, and then all the things that go with that, poor wound healing. So the diagnostic tests, again, are going to be our labs to check the levels of the hormone. We're going to check that stimulating hormone, the ACTH level, as well as the cortisol level in the serum. And there's also a urine test for cortisol, the 24-hour urine for cortisol. In addition, they're always going to do imaging, right? Looking for tumors or causes, CTs and MRIs to see is there a tumor on the adrenal gland, a tumor in the kidney, a tumor in the brain near the pituitary gland. So imaging studies is always going to look for abnormal growths or tumors. The labs, we can check the levels of our stimulating hormones and our hormones. And there's also a test. And the test, think of the test as playing with that negative feedback loop, right? So when we inject or administer a steroid, dexamethasone is a steroid, what would the normal response be of the ACTH level, do you think? So if you were to give someone IV dexamethasone, which is a steroid, think of the negative feedback loop. What should it cause the pituitary gland and the ACTH to do? Decrease, right? Because it's, remember, like your furnace. So if our steroid level is high, we injected some, then if the feedback is working normally, the pituitary should produce less ACTH, right? And eventually less cortisol. Abnormal response would be if the ACTH level stays the same or increases, and the cortisol level increases. Because that would mean there's a problem somewhere right there, right? There's a problem with the feedback, problem with the pituitary, Or is the pituitary fine, producing ACTH fine, but the adrenal isn't responding? Because it could be an adrenal tumor, right? Or the adrenal gland, we can have abnormalities from, maybe they had renal cancer, maybe they had pheochromocytoma. I know someone that had pheochromocytoma, so they had to remove the adrenal gland for that. So of course, it's gonna decrease their adrenal hormones. If you have one normally functioning adrenal gland, your levels should be okay. The treatment will depend upon the cause. If it's from a tumor, they can remove the tumor. So if it's a tumor in the pituitary gland, they can do a hypophyseectomy, which is surgery to remove the pituitary gland. If it's a tumor in the adrenal gland, they'll do an adrenalectomy. So depending on the cause. If it's due to long-term steroid use, they could try to taper the dose of steroids, right? Depending what they're using, it's always a balance, remember that balance. So if you have rheumatoid arthritis, or it's rheumatoid's the one I'm thinking of, maybe lupus, some autoimmune disease usually, and you're on long-term treatment for steroids, you can have Cushing's syndrome. So they'll maybe try to change the steroid or decrease the dose, watching your symptoms. In addition, there are some drugs that suppress the secretion of cortisol. And it's not on here, but obviously imaging studies to see if it's caused from a tumor. Also, they'll do bone scans because increased risk of osteoporosis. So for someone who's, has long-term, any endocrine disorder, really, they may order a bone scan to check for bone density. But the ACTH level can be monitored in the blood as well as the cortisol, right? With thyroid, we said we can monitor the TSH level as well as thyroid hormone. So really, your serum labs are key to diagnosing any abnormalities. So there are drugs to decrease production of cortisol, anti-adrenal drugs. They're not going to cure the cause, right? They're not going to cure the cause. They're only going to decrease the production of cortisol to lower the cortisol level. And the drugs are ketoconazole or Nizoral and aminoglutamide. They block the synthesis of corticosteroids. A new one is the Signifor, which again causes inhibition, but this works on the ACTH. So Signifor decreases ACTH secretion, and we know ACTH stimulates the adrenal hormones. And if it's specifically a cancer or tumor, they use a drug called mitotane, which is an anti-neoplastic, so it destroys adrenal cortical cells to treat any cancer of the adrenal gland. So that's why we say, depending on the cause, right? What's causing the Cushing's disease or Cushing's syndrome. So ketoconazole is the one drug that they picked. Again, it's in your pharmacology book for review. It inhibits cortisol synthesis. It's given orally for Cushing's disease. It also is used for other,
Say they have shampoo.
yeah, a shampoo. It's an antifungal. Yeah, it's an antifungal too. Adverse effects are pruritus, headaches, nausea, vomiting, impotence, hepatotoxicity, and it should be taken with food, opposite of some of the other drugs we heard. Not safe to use in pregnancy. Nursing interventions for excess cortisol or Cushing's, assess for clinical manifestations, monitor glucose level, monitor electrolytes, monitor vital signs, weight gain, educate the patient about the complications, medications, encourage follow-up care, good skincare, healthy diet and exercise, because they're gonna have hyperglycemia, tend to retain fluid, gain weight, so try to, encourage healthy diet and exercise, and decrease risk of infection. Again, once treatment is started, the clinical manifestations aren't gonna resolve quickly, it happens over time. So that's our Cushing's. So with Cushing's, we're gonna see increased cortisol levels in the blood and the urine, right? And decreased ACTH if it's a primary problem with the gland itself. If it's a problem with our pituitary not producing enough or producing too much ACTH, then we're gonna look more at the ACTH level, okay? And then the other was that giving them some steroid IV to see if they respond normally, if the feedback mechanism is working. Okay, so you got the pictures there, the sort of two pictures for all the clinical changes. So the opposite side, and again, as you can see, one of my study tips to learn endocrine, compare and contrast, right? Because you have hypo, hyper, hypo, hyper. So compare and contrast next to each other, a good way to study these two endocrine disorders. So now we're gonna talk about adrenal hormone insufficiency, not enough, caused by destruction of the adrenal gland or deficient adrenal cortex functioning, resulting in low cortisol. Remember, we need cortisol for dealing with stress. We can't live without cortisol. We can't live without it. It affects many physiological processes in the body. Glucose levels, metabolism of protein, inflammatory reaction, regulation of fluid and electrolytes. We talked about primary problem is a problem with the gland itself. The gland, we have two of them. The most common is the autoimmune form, which is called Addison's disease. Also could be from an infection, tuberculosis, cancer, atrophy, or surgical removal of the gland. Maybe the patient had renal cancer and had to have their kidney removed, or maybe they had surgery to that, radiation for cancer, and it damaged the adrenal glands. Also, adrenal insufficiency could be caused from suddenly stopping your corticosteroid medications. So you learned about corticosteroids last year. Did you guys remember them saying you should never just suddenly stop your steroids, you should taper the dose? Because if you're taking steroids, so go back and look at the negative feedback loop, right? So if you're taking steroids exogenously, it's gonna affect your negative feedback loop. It's gonna tell your pituitary gland not to produce as much ACTH because you're taking exogenous steroids. So if you just stop that all of a sudden, the mechanism doesn't work right. So the patient could all of a sudden have a very low cortisol level and have adrenal insufficiency. That's why the steroids need to be tapered off, never just suddenly stopped. We can also see adrenal hormone insufficiency as a postpartum complication, or if someone has hemorrhage or a blood clot. So many different causes, but the most common really is the autoimmune form or the Addison's disease. Clinical manifestations, we have up here, hypoglycemia, hypotension, orthostatic hypotension, or postural hypotension. Those mean the same, right? The blood pressure drops as you change positions from lying to sitting to standing. So orthostatic or postural hypotension means the same thing. Nausea, weight loss, fatigue, hyperpigmentation, because it affects the melanocytes, our skin color. So you have hyperpigmentation usually in the knuckles, knees, and elbows. Hyponatremia, because the adrenal gland cortex also produces what other hormone besides cortisol that's important? Aldosterone. Aldosterone regulates sodium in water. So the adrenal cortex we're focusing on the cortisol, but it's also aldosterone. So it is going to affect our blood pressure because it affects our sodium and our water balance. Abdominal pain, joint pain, mental status changes, muscle weakness, craving salt. Without aldosterone, the sodium levels are going to be low, so that they may be craving salty foods, craving salt. Diagnostic tests are going to be the labs. Again, we can check levels of cortisol, levels of ACTH. We can certainly check the sodium level, potassium, and glucose level, putting all the puzzle of the pieces together to come up with a diagnosis. But then one of the specific diagnostic tests for diagnosing Addison's is the ACTH stimulation test. Again, y'all gotta keep looking at that feedback mechanism, that picture in that slide. So if we get a baseline serum cortisol level and then administer ACTH, right, that's the ACTH that we need to produce the cortisol, then normally we would expect the cortisol level to go up, right, because we're giving ACTH. It should signal the adrenal to increase cortisol. So the normal response would be cortisol increases in response to giving the ACTH. If after 30 minutes, 60 minutes of getting it being administered, the ACTH, the cortisol level does not increase, stays the same, or goes down, then we know there's a problem with the adrenal gland, that it's not responding to the ACTH. So the labs are always important with these adrenal disorders. And just know with cortisol, the levels fluctuate with your circadian rhythm. So they may check a morning one and an evening one because the normal level fluctuates as our day goes anyway, our normal circadian rhythm. And then again, they're gonna be checking sodium levels, potassium levels, glucose levels, and imaging studies always help to identify any tumors. Treatment is again, it's great if we don't have enough hormone, insufficient, we have synthetic hormone replacement that would be needed to be taken daily and lifelong. So we have plenty of different forms of steroids, hydrocortisone, methylprednisolone, prednisone, dexamethasone. Those are all steroids that can be used for replacement in Addison's disease or any adrenal insufficiency. And sometimes they also need to replace the aldosterone that's missing, and they'll do that with a drug called fludrocortisone. Also, increasing salt intake and monitoring fluid and electrolytes is important. We said aldosterone regulates our fluid and electrolytes. Patient teaching is important. And what's key with this, Addison's or adrenal insufficiency, in times of stress, our body needs increased levels of cortisol. And I'm gonna give you a case scenario, a real life case that I talk about that in a minute. And then the other thing, actually pretty much any disorder that's chronic and lifelong, you encourage the patient to either wear one of the medical or bracelets or necklaces that says the condition in case they're ever lethargic, comatose, or something and they can't speak for themselves so people know they have this chronic disorder. Yes?
Can you repeat what you said about the fludrocortisone?
Fludrocortisone is a mineral corticoid, which is our aldosterone. So the adrenal cortex produces two important hormones, cortisol and aldosterone. So depending on the levels of the sodium and everything, they may need to also replace the aldosterone if that's insufficient, and they do that with fludrocortisone. All right, so here's my real case scenario for Addison's. We had a patient who had some major surgery, was in ICU, was out on the med-surg floor. Pressure was low all day, hypotensive. The nurses would call the surgical resident. He'd say, order an IV fluid bolus. 500 mLs. The nurse would recheck the blood pressure, it's still in the 80s, right? Give another fluid bolus, another liter of fluid. Recheck the blood pressure, it's still in the 80s. Couldn't get that blood pressure really above 80. The glucose level was low, the patient was lethargic, and the family kept saying, trying to say, but the surgical residents weren't listening for some reason. The patient has Addison's disease, the patient has Addison's disease. The patient had surgery and complications and ended up in ICU, and they didn't increase her cortisol level. I don't even think she had it ordered. So finally, this really went on for 8 hours for a shift, and this is how nurses advocate for patients, because we nag them. And it's like, the family, finally they called me and they're like, they're not listening to us. Our mother has Addison's disease. She needs cortisone and additional. Finally, they ordered IV doses, hydrocortisone, and the patient improved. But just an example of, everyone's focused. So the surgical residents were focused on their surgery. And you guys know, what's the response to hypotension? IV fluids, right?
Yeah.
But this patient, because of her adrenal insufficiency, Addison's, needed increased cortisol. So when a patient's having increased stress, so trauma, major surgery, an infection, they need increased doses of cortisol. That's the normally cortisol in a normal person, when you're in times of stress, it increases in your body, that's what it does. So we have to remember, when we have someone that has adrenal insufficiency, Addison's, they need increased doses given to them because their body can't normally respond. So hydrocortisone, again, I think it's a review for you guys. It's a glucocorticoid. Just remember, they all have a lot of side effects, right? And major teaching is the patient should never abruptly stop the dose. They shouldn't run out or not take it. They need to taper the dose, and they need an increased dose in times of stress. Corticosteroids has multiple adverse effects. Many of them are what we see under Cushing's with excess, right? Same type of drug, right? Hyperglycemia, increased infection. Over time, they can cause osteoporosis, fluid and electrolyte imbalances. They can have mood and psychological effects, steroids, right? High dose steroids can make people very labile, even psychotic, and can also cause cataracts, glaucoma, impaired wound healing, and many drug interactions. So again, the steroids are wonder drugs, right? I've seen them improve people's condition for asthma, CHF, pneumonia, sepsis, right? We use steroids for everything, but they have side effects. Short-term use, usually that's not a problem. It's long-term use that we see these issues. So the fludrocortisone, we said, is to replace the mineral corticoid or aldosterone. It's for adrenal insufficiency, and it's given orally once a day. Adverse effects are written there, you can read those: hypokalemia, sodium and water retention, hypertension. So as with thyroid, there's the extreme abnormal. So adrenal insufficiency, again, it's not like one thing, it's a continuum, right? You could be a little bit deficient, you can be medium deficient, or you can have a large deficient adrenal hormone, causing the extreme end of the situation. An adrenal crisis or adrenal insufficiency can be life-threatening. Symptoms are all of the Addison symptoms, like worse: hypotension, orthostatic hypotension, low glucose, abdominal pain, fever, vomiting, hyperkalemia, which we know could lead to dysrhythmias, rapid weak pulse. It can lead to circulatory collapse and shock. So adrenal crisis is sort of a crisis, critical situation. You would need to stabilize the patient with IV fluids, give them some IV steroids, Again, these extreme cases are usually triggered or precipitated, that means the same, triggered or precipitated by some stressful event, an illness, surgery, trauma, something else going on. And the treatment would be, think of what the problems are. By now, you guys have been in nursing to know if someone's hypotensive, what do? IV fluids, right? Someone's low blood sugar, we give them sugar. So we're gonna give them, and in this case, we said they also may have a low sodium. So isn't it great that they make D5 normal saline? So we can give them fluid boluses, we can give them dextrose and sodium. Correct any electrolyte imbalances. Steroids come in an IV form, so you can quickly increase their cortisol level by giving IV steroids. If the hypotension persists, we can use vasopressors, but vasopressors are not the first drug to go to. Vasopressors squeeze the system, right? They contract your vasculature, they squeeze. We don't want to do that. Let's correct the fluid problem first, right? So give fluids first. Glucose if needed. And you know all the forms you can give glucose, right? You learned about that last Thursday. IV, you can give it buccal, gel, sub-Q, IM. If someone's unconscious and they need glucose, we can give it in many different forms. So nursing care, obviously vital signs are always first. Monitor INO, weight, monitor fluid and electrolytes, orthostatic blood pressures, and salt intake. And actually, people that have adrenal insufficiency or Addison's are encouraged to have sort of an emergency kit with them in case they do become lethargic or unarousable, that the family members or someone could administer an injection of steroids. So they actually have an emergency kit for them. Any questions about Cushing's or Addison's? Again, comparing and contrast is a good way to learn it. I don't want to eliminate, but there are other endocrine disorders. So we said the adrenal gland has a cortex and a medulla. So you guys can read the pheochromocytoma is a problem with the adrenal medulla. And the drugs, the hormones it produces are epinephrine and norepinephrine, which you know affect the heart rate and the blood pressure. So you can go ahead and read that. Adrenalectomy may be one of the treatments we do. So that would be removing one or both of the adrenal glands. If it's both, then they're gonna need lifelong hormone replacement. If it's one adrenal gland, the other one may be enough to maintain normal adrenal hormone level. So pre-op, monitoring vitals, cardiovascular, blood sugar. Post-op, observing for hemorrhage and shock, hypotension, prevent infection, steroid replacement, and monitoring their glucose levels. So again, think of what the hormone regulates, and then it'll be common sense, what are my nursing interventions? The list of patient problems are basically what we said: fluid and electrolyte, skin integrity, body image, right? Imbalanced nutrition. With Cushing's, we tend to have weight gain, right? Weight gain and weight loss. Risk for infection, knowledge deficit about medications and treatments, and signs and symptoms of the extreme cases occurring. So basically, what do you think the goal of treatment is for the adrenal disorders? Good, to normalize the hormone level, right? And maintain fluid and electrolyte balance and prevent complications. That's kind of our goal. All the diseases you've learned about, isn't prevent complications on the list? This little chart you guys can fill in. I thought it was a cute little thing I did for review. You can write C for Cushing's, A for Addison's. And the next slide Just again, this is not gonna be tested on, but I want you to know there's other endocrine disorders. You may hear of them. Syndrome of inappropriate antidiuretic hormone or diabetes insipidus. So there are other endocrine disorders. We're just picking the more common ones and the ones, the exemplar for our curriculum. But there are pituitary disorders as well. So take 5 minutes, this is a shorter case study, to look at the case study together, and then we'll review it. It's the endocrine case study that was posted in course content. The glucose is on the low side, the sodium's low, the potassium's high. What does a BUN of 30 kind of indicate to you? What are you thinking when you see dehydration? Excellent. So we got hyponatremia, hypoglycemia, elevated potassium, BUN increased because she had to eat in nausea, vomiting, yes.
So we're saying this is all from the absence going off the prednisone, but.
No. So wait, Addison's is the autoimmune adrenal insufficiency. So I could put adrenal insufficiency doesn't necessarily mean Addison's. Addison's is one cause of it, but she suddenly stopped her glucocorticoid that she's taken for years. So the negative loop, the feedback loop isn't working. It's used to having a high level of steroid because she's been taking prednisone. Now all of a sudden doesn't take it. Well, the hypothalamus and pituitary aren't functioning. They're used to the high level because she's been taking prednisone. So now the pituitary isn't producing enough ACTH. That's why she has adrenal insufficiency. Because the feedback loop got screwed up. It was used to having whatever she took, say 40 milligrams of prednisone every day. Now you stop it all of a sudden. Well, the negative feedback loop is going to take a while to catch up, to adjust to that. And that's what caused the adrenal insufficiency.
I understand all that, but I don't understand why we're not looking at her being off to Synthroid.
Oh, we are too. This case study was focusing on adrenal, but absolutely we got to check her TSH level as well. And the TSH would probably be high if she wasn't taking her thyroid. Yes, sorry. This was just focusing, in the case studies, I tend to focus on one or the other. So AI is adrenal insufficiency, right? Adrenal insufficiency. Too little, insufficient. One of the causes is autoimmune Addison's, but we could be suddenly stopping the steroid. Chronic steroid use could cause it. What other lab tests should be done to confirm the diagnosis? Labs, right? Just draw the ACTH level, the cortisol level. We could do an MRI, but we probably don't need it. It's pretty, we're like detectives. Being that she hasn't taken the meds for 3 days, that's probably the cause. So just draw the ACTH level and see what it is, draw the cortisol level. What other clinical manifestations will we test for?
Signs and symptoms of hypoglycemia?
Yep, hyperkalemia, hyponatremia we already see, weakness, diarrhea, fatigue, tachycardia, depression, hypotension, confusion. It could be a change in mental status. Abdominal pain, good. So all the clinical manifestations of adrenal insufficiency should go there. AI, right? Adrenal insufficiency. What complication is the patient at risk to develop? So with adrenal,
Hypotensive shock.
yeah, what do we call it?
Adrenal crisis?
Adrenal crisis, which is basically hypotensive to the point that you could have circulatory collapse or shock. And what's the treatment?
The
Put her back on the
IV5.
steroids.
Yeah, but until then,
Well, we don't-
fluids, what kind of fluids?
D5.
D5 normal, some fluids with glucose in it and sodium, right?
And the
Because we
IV
saw the
prednisone.
sodium was low, the glucose was low, those go along with adrenal insufficiency. So give IV fluid that'll increase the blood pressure, right?
And IV
Increase the sodium and give the patient some glucose. So IV fluids, what else?
IV steroids.
And IV steroids, good. If someone can't take PO, we have an IV form of steroids, IV fluids, support them with whatever they need for their basics, right? Meaning, if they need oxygen, control the other things, but IV fluids and replace steroids or cortisol, corticosteroids with IV doses. Replace electrolytes as needed. How could we have prevented this crisis from happening or these adrenal, how could you prevent it?
Or they could have given IV.
Give her her meds, if she couldn't take them PO, we could have given IV, right? Synthroid comes IV, prednisone comes IV, and antiemetics, good. Taper the doses, never abruptly stop because the patient can go into adrenal insufficiency. And I think that is it. So remember, ATI has targeted assessment for endocrine if you choose to do that for health as well as Pearson's.